Okay, so today the topic for discussion is the contrast echocardiography. So what is the contrast and why we need it? So what is ultrasound contrast? So red blood cells are very poor reflectors of the ultrasound because the impedance, acoustic impedance between the surrounding tissue and RBC is very minimal. So you cannot segregate and does not reflect the ultrasound. But with the aggregation of the RBC that occurs when there is a slow flow or there is a clot, then it will become the echogenic. So it will appear on the echo as spontaneous echogenic contrast or the clot, which is hyperechoic. So normally the RBCs which are in high velocity, they do not produce any ultrasound contrast. So we will require some agents that will increase this echogenicity of this plasma normal blood flow, and which will also then further we can further then conclude according to the how much the contrast it is producing and how the shunt it also going from there. So these microbubble agents have similar to RBC properties, and when injected intravenously they remain entirely within the vascular compartment, but they does not cross endothelium. So there is a topic for discussion is right versus left heart contrast. So the right heart contrast versus left heart contrast. So right heart contrast which we will all do practically most of the time, and the left heart contrast nowadays most of the times we generally don't do, and it is most of theoretical purpose only. So right sided is the agitated saline, because the bubble diameter is greater than the diameter of the pulmonary capillaries, so it cannot traverse the pulmonary microcirculation. So without any shunt, intrapulmonary shunt or any shunt at the cardiac level, it cannot appear in the left sided chambers like the left atrium, left ventricle or the aorta. So it will help in diagnosing the PFO, ASD, LSVC, etc. We will see subsequently. And the left heart contrast is the we will require commercialized micro bubbles which it is diameter of the 1 to 5 micrometer, and they can also traverse the pulmonary capillary bed. So then we can also image the left sided structure with this ultrasound contrast. So right heart contrast, how to prepare? So there is a 2 syringe with 3-way coke, 9.5 ml of the saline in one syringe and 0.5 ml of the air in one syringe, and then it is prepared by forcefully injecting the solution from the one syringe to the other and doing it rapidly. So there will be turbulence, and which will result in the creation of the large number of the microbubbles, and that is suitable for intravenous injections. For the opacification, the dose, how much contrast we will require, it is from 1 to 5 ml and followed by rapid saline push, because if we does not push it with a rapid saline, then it will distract before it can even appear in the right atrium. So these are the uses, common uses for the contrast. So agitated saline is suited for this purpose because the microbubbles persist to traverse to opacify right heart chambers and any shunt lesion like ASD, PFO, pulmonary AV fistula, etc. But it will not gain access to left chamber as we have discussed, because it cannot traverse the pulmonary circulation because they are larger size, more than in RBC size. So capillaries are very smaller size. So in the ASD, it is within 3 to 5 cycles after injecting the contrast and opacification of the right atrium, it will also opacify the left sided structures. And in PFO, it might or might not opacify, but with Valsalva and cuff we can confirm it is with right to left shunt. And in pulmonary AV malformation, there is within 5 to 15 cycles it will opacification. This all we will see in subsequent slides. And also second is the anomalous drainage of the systemic veins to the left atrium. So LSVC to coronary sinus to LA, or LSVC to LA, or RSVC to LA. Any other also many rare anomalies also we can diagnose. So this is the normal contrast study. There is no shunt, so the contrast opacification from the venous, it is opacifying right atrium, then subsequently right ventricle and pulmonary artery, but it will not opacify the left atrium or left ventricle. There is a IS dropout at the superior portion, which might look like ASD if we not seen carefully, but this contrast echo is essentially normal. That suggests that there is no shunt. So this is the same echo, and they suggest you there is no shunt, but there is a IS is very floppy, and it is also looks like that might be some atrial septal defect. So in a diagnosis of the ASD, generally when we do apical 4-chamber view, there will be IS dropout in many cases. So because why this happens? Because there is a ultrasound beam is parallel to interatrial septum in 4-chamber view. So we require the beam to be perpendicular. That's why the diagnosis of ASD requires a good subcostal window. So without a good subcostal window, many times we either falsely diagnose the ASD because of dropout, or sometimes even miss the large ASD. Occasionally from the coronary sinus or the IVC also may be mistaken as ASD if it is near the IS. So there is a in this video there is a opacification of the right atrium from the contrast, and there is a negative contrast shadow, which is because of there is a non-contrast shunt occurring from the left atrium to right atrium, left to right shunt. So it is producing the negative contrast. There are also some microbubbles traversing to left atrium, because there is some phasic variation and some amount of the right to left shunt is there in ASD because of the respiratory variation and changes in the compliance of the right ventricle and left ventricle. So this is the in this case there is a clearly ASD is visible, but contrast echo in many cases when there is a diagnosis is not as clear as this case may help. There is the PFO. So the PFO, the shunt is many times phasic with the respiratory cycle, and without Valsalva and a cuff, there may be miss of the PFO. Many young patients without any comorbidities when referred with for cryptogenic stroke and for further evaluation, when we do 2D echo and we report that there is no any abnormality and normal 2D echo, but we should always do a contrast echo with Valsalva and cuff to allow the detection of the small PFO, and which can be mounted as the cause of the cryptogenic stroke. And if there is a PFO present in the patients without any other etiology for the ischemic stroke, then it might require the PFO device closure. So diagnosis of the PFO is always missed unless you are carefully looking for it. Same happens with the platypnea orthodoxa syndrome. So what is the platypnea orthodoxa? The patient feels some dyspneic and desaturated when it is in the sitting position, but when it goes to lying down position, it is all right. So many times physicians label this as the pure functional and without doing any further workup. But if you measure the saturation in the standing and supine position, then it may suggest and give clue for this syndrome. So this is the still image of saline contrast and this platypnea orthodoxa syndrome. So there is a PFO between right atrium and left atrium. This is a TE view, 4-chamber view, zoom view. So there is a from the SVC to RA and there from the LA. So there is a PFO, there is no flow across it. So if you do contrast echo and then you will report is a normal, there might be some 2D abnormalities or artifacts. But if you ask patient to the cuff or Valsalva, or even in these patients like platypnea orthodoxa, if you make them to sit up and then this kind there is a large shunt happening through the PFO from right atrium to left atrium. So saturation is dropping from 96 to 86. That is suggestive of right to left shunt, and that is cause of the this desaturation. Same happens with interatrial septal aneurysmal. So in this image there is a dropout with there is a thin membrane like interatrial septum, and as we know there are the 5 types for interatrial septal aneurysmal, and the PFO is associated highly associated with this kind of septal aneurysmals. So aneurysm without a PFO, there is very low risk of the stroke or other embolize, but if a PFO, this PFO is associated with IS aneurysm, then the risk of the stroke also increases. Though, so we should carefully look for the PFO in all these cases also. So next is pulmonary AV malformations. The shunt is here is delayed from right to left shunt. So the after 5 to 15 cycles, the contrast will appear and it will be a phasic contrast. Like first there is RA and RV is totally opacified, and then it will opacify the left atrium and then left ventricle, and then the intensity of the contrast will be almost equal in all 4 chambers. Then on further time the intensity of the contrast in the right atrium and right ventricle will decrease, and in left atrium and left ventricle it will also increase. So, so the contrast will build up with persistently and slowly. So this is the suggestive pulmonary malformation. So this is the video for that. As we can clearly see, the initially the right atrium and right ventricle opacified, followed by left atrium and left ventricle, and the contrast also disappearing from the RA and RV. So then there is abnormal extracardiac communication. So injection of the agitated saline in the lower extremity veins and individual with azygous continuation of the IVC and interrupted IVC will show the contrast in superior portion of the RA. So it is suggestive that the blood is going from the IVC, then to azygous continuation, then draining into SVC, and then opening into RA. So if it was a normal case, the contrast will appear in the lower part of the atrium from the IVC. But in this interrupted IVC, contrast will appear coming from the SVC. Then also injecting the saline into the left upper extremity vein results in the ossification of the dilated coronary sinus, and then this dilated coronary sinus drains into right atrium, and it is suggestive of persistent LSVC. So the LSVC, so persistent LSVC is suspected when there is a dilated coronary sinus in the absence of the cause for elevated right atrial pressure. So sometimes when there is a high right atrial pressure and severe TR, the coronary sinus may be dilated because of the break pressure. But if there is no any right atrial pressure abnormality, and if there is a coronary sinus dilated, then first differential diagnosis is persistent left superior vena cava. So it can drain directly into coronary sinus, or directly into the right atrium, or directly into the left atrium. And according to that, we might or might not find the coronary sinus which is dilated. So injecting the contrast from the left any antecubital vein or other vein, and then following it shows the appearance of the contrast in the coronary sinus, and then followed by into RA and RV. So it is suggestive of LSVC to coronary sinus to RA. If it appears directly into the RA, and then it might be the LSVC is draining into the SVC, or there might not be any abnormality at all. But it can also drain into left atrium, and which can be the cause of the desaturation. So this sometimes this is also called derupt coronary sinus, because the portion between the coronary sinus and the left atrium, it is not there. So the blood drains directly from the coronary sinus to left atrium. So this generally persistent LSVC which drains into CS and into right atrium, it is not any much of a clinical significance in day-to-day living, but some cases where that may be troublesome is when we are implanting the pacemakers or AICD, or when we are taking the patient for the surgery and we require cardioplegia, and at that times may require selective cannulation of both vena cava. Yeah. So this is a video showing there is a subcostal fourth chamber view, which is shows the first contrast ossification in the coronary sinus, which is the inferior most portion. Then it is going into the right atrium and right ventricle. So this is suggestive of LSVC to draining into CS into RA. The same picture, still image is also seen on the left side. That first it is the left coronary sinus that is ossified, followed by right atrium and right ventricle. On right side there is a rare abnormality. Still image showing that in a subcostal approach we have injected the saline contrast from the right and left, both upper limb vein, and it is resulted in ossification of the left atrium and left ventricle, because there was a abnormal connection between SVC and into the draining into LA. So this is a very rare abnormality, and when we injected contrast into the IVC, it is resulted into RA. So IVC is connected into RA. So we can diagnose this rare abnormalities from contrast echo as well. Then this is the short axis view showing negative contrast into the from the main pulmonary, from descending thoracic artery to main pulmonary artery. But there is also some phasic left to right and right to left shunt, both is seen in this color Doppler also and this bubble study also. So it is showing the early case of the Eisenmenger. The next image shows there is a short axis view showing MPA and aorta, and there is on 2D there is no connection, there is no any structure between the aorta and MPA. So there is a suspicion of the AP window, and when we inject the bubble contrast, it goes MPA to directly into aorta. So this suggests us the two things. First, there is a connection, and this is the large AP window between the aorta and the MPA. And second, from the shunt is right to left. That suggests that the patient is having severe PH, and this is the case of the Eisenmenger syndrome. So the same thing we have discussed there in first portion, and there was some phasic right to left shunt and predominantly left to right shunt. So it was the case of early Eisenmenger with PH, and the second, as we discussed, there was aorta pulmonary window with severe PH. So this is the most important thing. So any times when there is a persistent cyanosis in any child, so we always think of congenital heart disease with right to left shunt or other respiratory cause. So these things, negative saline contrast study is rules out the congenital heart disease and right to left shunt as a cause of cyanosis. So there are the two cases both we will look into it. So first is a 14-year-old boy with mild cyanosis and early childhood, and there were no other symptoms. Whole examination was also normal, X-ray, ECG and 2D echo also normal. So then we have done saline contrast echo, and there was no any shunt. So then it led that the patient does not have any respiratory or cardiac issue, and then further we have evaluated for the cyanosis, and it was found to match hemoglobinemia. Second case is 17-year-old boy with mild cyanosis and somewhat dyspnea since early childhood. ECG, X-ray was normal. Echo suggestive of mild pH and no other cardiac shunt. HRCT was done with CTPA to rule out any other respiratory causes, and it was reported normal by the radiology department. So then because of very high index of suspicion, saline contrast echo was done, and it was delayed right to left shunt, which is typical of pulmonary AV malformation. So then CT images were again reviewed, and it showed that there was multiple bilateral tiny pulmonary AV malformation, and because of that there was a right to left shunt, and this was missed in the previous CT scan because the CT is having around 1 to 2 mm cuts, and very tiny malformation might not even be visible, or it will require the very careful looking. So this type of the things can be missed even if we would do extensive investigation. So in these cases, when there is a desaturation in otherwise healthy person with all normal investigations, doing a contrast echo, it excludes the right to left shunt as the cause of the desaturation, and we can go for further workup for the other systems. So this is the flow chart. As we all discussed, the normal saline contrast is it will only opacify RA, RV followed by pulmonary artery, but it will never go to left side. So if there is a saturation on the left side, then we will have to look where it is first appear. So if it is in the left ventricle, it can be VSD. First it is cannot be the shunt, which cannot be left to right shunt if it is occurring into left side heart, because it has to be right to left shunt. Then the contrast from the right side will go into left side. So any case of VSD or ASD with Eisenmenger, it will produce this kind of the thing. So VSD with pulmonary stenosis, in which also there is a right ventricular hypertrophy and right ventricle having a more than systemic pressure, and VSD with Eisenmenger and pH. In both these cases, there is a contrast appear in the left ventricle. If it appears in the aorta, if it is appearing ascending aorta, then as we already seen, it can be because of epi window, and if it is appearing in the descending aorta, then it can be PDA with Eisenmenger. We have seen both the cases already. Now if it appears it is in the right atrium, but it goes to left atrium within 2 to 3 cycles. So it can be ASD with PS or the PH or patent foramen OL. And if it there are also rare abnormalities when it can directly go into left atrium, like pulmonary aorta to LS shunt and some other causes, but this is very rare, and in the AV malformation, pulmonary AV malformation, it will go after 5 to 15 cycles. So if it appears in the left atrium directly without entering into right atrium, then we have to look for the site of the injection. If it given from the left vein, upper limb vein, then it might be LSVC or SVC, both draining into LA with or without unroofed coronary sinus. If it given from the right upper limb, then it can be SVC into LA. As we seen, it is very rare. And if it is from lower limb, then can be discontinuation IVC, or it can be draining into LA with miscommunication. The next use of the contrast echo is the Doppler signal enhancement. So many times the TR is very trivial and jet is very faint, as seen in the upper image, and if we measure PA pressure, it might be velocity is around 2.5 or 3 only, and we may report it as the mild pH. So the PA pressure from the TR jet and RV systolic pressure should never estimated if the jet is incomplete and with shown like this. In that cases, we can use the bubble contrast and redo the continuous wave Doppler, and in lower image as it shows, the pH was significant with velocity almost touching to 4, suggestive of a severe pH. So the cases where the estimation of the pulmonary pressure is important, but TR is not that much, and jet is also incomplete, we may use the bubble contrast echo and we can estimate the PA pressures. The thing is, it also enhances the color Doppler. So the trivial TR, when we have done with contrast echo, bubble contrast echo, there is a dramatic increase in the jet and intensity of the color flow. So it will overestimate the tricuspid agitation. So contrast echo should never combine with the color Doppler, otherwise it will overestimate all these reasons. This is the use most of the have already used for this indication when we are doing pericardiocentesis for patient with large effusions or the tamponade. After doing the puncture, we always first look for the position of the needle, and we can do it with the bubble contrast echo because it is very rapid and very safe and easily preparable. And this should be done before inserting the guide wire and dilating with the dilator and inserting the sheath. Because the pricking needle is even though large bore, many times even if you rupture the ventricle, it might not result in the further perforation and the massive blood loss. But if you dilate it with the 6 French or 5 French sheath, and then it might lead to a cardiac rupture, and that might be patient might not be savable at all. So in this video we can already see there is a contrast appearing in the pericardium, and so we can safely then insert the guide wire, and we can do pericardiocentesis from there. So one use is the leak and the obstruction in the intra or extracardiac baffle. So many congenital procedures are complex like atrial switch operation with some muscle and sending operation. So there is extensive baffles, systemic and pulmonary veins. So in that case, 2D echo might not give you good estimation of these are the connected and what is the flow, and also if there is any obstruction or not. And many times this post-operative patient we do not find any good window. So injecting the bubble contrast then delineates from which there is a systemic flow is going, and the other part which is left, it was the pulmonary flow. So we can, in these cases where there is a atrial switch performed and many times they are not possible that it can be done or not, we can go by this. There is a normal functioning of the palliative surgeries like bidirectional lane and the Fontan relies heavily on the appropriately low PVR. So many times when there is a PVR is high or a borderline, there we may leave small fenestration, so it can cause a decompression. Whenever there is a pressure from the right sided circuit increases, it will decompress to the left side from this small fenestration, and so it will result into somewhat hypoxia, but at the cost of the frontal procedure will not fail. So in that cases, the fenestration acts as a safety valve, but many times because of suboptimal echo window we might not see this fenestration. So in that case, saline contrast may help to look for the patency of the fenestration. So now the next topic is the left heart contrast. So right heart contrast, as we discussed, it was very easy to prepare and very easy to practically implement. But in the left heart contrast, we will require some manufactured ultrasound contrast agents. These are the artificially prepared micro bubbles with inert gas in the core, and outer shell is made from the albumin or any other tissues. So properties of the ideal contrast agent. So first it has to be high echogenicity. Second is linear relationship between the concentration and the intensity of the signal, and ability to passage the pulmonary capillary bed because we want to evaluate the left side structures. Second is the stability and persistence, and ability for the rapid destruction for a perfusion imaging, which we'll see in the next slides, and less artifacts and the safety. So these are the old generations of how ultrasound contrasts are evolved. The first was only inert free gas bubble which could not traverse the capillary beds. So then we have encapsulated with some albumins and other macromolecules, so it can traverse, but the stability was not good. So further next generation, the stability was improved, and in the latest third generation, there is acoustic properties also linear and control. So the second generation contrast agent consists of the thicker outer shell of the albumin or the phospholipid, and there is an inert gas of nitrogen or fluorocarbon, and these are the smaller in diameter than the RBC, around 2 micrometer, and they can pass the capillary vessel. And these are also negatively charged phospholipids because it will prevent them from the aggregation. So these are the commercially available the contrast agents. So it is Sonoview, Optician, and Luminis. So Sonoview is sulfur hexafluoride, Optician is perfluoropropanate, and Luminity is the perfluorine. So diameter is around 2 to 8 micrometer, ranging from 2 to 8 to 1 to 2. The Sonoview is available in the Indian market. Optician is also available, but Luminity is not available in Indian market. So the clinical safety of the ultrasound agent, the severe reaction is extremely low, 1 in 10,000, and this also contraindicated in the patient with hypersensitivity, and but it is not contraindicated in presence of cardiac shunt or pulmonary hypertension. There can be anaphylaxis, angioedema, urticaria, seizures, as can happen with any drugs. So this is the Sonoview pump. It comes in the powder form, which should be prepared, and then it can given from the bolus or intravenous injection from this pump. So this is the vial from which we have to withdraw, and then it has to be continuous infusion or the diluted bolus. So bolus injection around 0.2 to 2 ml of the contrast is enough for the opacification, and followed by 2 to 5 ml of the saline plus over the 10 second. So there is a rapid increase in signal intensity, and then there is a plateau phase, and from there is a gradual decay. Okay. So the most common use are the endocardial border delineation and left ventricular opacification. And also as we have used in the right sided contrast, we can also use a Doppler signal enhancement with left sided contrast. So continuous infusion, it gives you the steady state concentration of microbubbles, also decreases the artifact, and because it is the consistent and the plateau nature is also maintained, it will help in the studies like the perfusion imaging, myocardial blood flow, and coronary flow reserve calculation. It can be also be used for the endocardial water or LV opacification, but for that you can also use bolus infusion. So ultrasound interaction with though this is the pure physics part of how ultrasound interacts with these contrast agents. So there are the three type of the responses: fundamental frequency, harmonic frequency, and stimulated acoustic emission. So ultrasound interacts with the microbubble, and then it will also there will be pure reflection of the beam at the transmitter frequency, also called the fundamental frequency, and it is dependent on the size and the frequency that was transmitted. Second is the harmonic frequency. So with a higher intensity, it will begin to resonate, and it will also transmit the frequency that are in the double of the baseline frequency. So from a 2 megahertz beam, it may also transmit 4, 8, and 16 megahertz. So this is called harmonic frequency. It increases the overall image quality. Stimulated acoustic emission is when you are increase the energy level. This results in the bursting of these micro bubbles, and with this burst there will be multiple broad range of the frequency and very high intensity amount of acoustic energy is released, and that will also pick up by our Doppler signal. Then it is the low mechanical index imaging. Now the mechanical index is the power of the ultrasound beam. So generally when we do any echo or ultrasound, the mechanical index we put is 0.9 to 1.5. At this we can use for the imaging of the tissue, as we have used routinely. But at this mechanical index, it will degrade this commercially. We have used ultrasound particles. So for this ultrasound with contrast, we have to use the lower mechanical index. So many dedicated machines now gives you the mode for contrast imaging, and it will shift the mechanical index from 0.91 to less than 0.3. And at this low mechanical index, the bubbles are not destroyed, and it will result in the continuous acoustic emission, and so we can image real time. And so these are the mechanical index and their behavior in ultrasound bubble behavior. So 0.1 mechanical index, there will only be linear oscillation. From 0.1 to 1, there will be non-linear and high harmonic oscillation, and from more than 1, there will be degradation. Now there are the artifacts. So we can when we are using contrast agent for this ultrasound, we have to aware of all the artifacts, because the first is the attenuation artifact. So the contrast agent are very highly reflectile of the acoustic energy, so very potent reflector. So when they are in very high concentration, then it will reflect all the energy and all the beams from the proximal part only. So the distal imaging will show very black and very hypoechoic. So as seen in these images, the RA and RV are very hyperechoic and well visualized with this bubble contrast, but left atrium, left ventricle are buried in the shadow. So this happens more with the bolus, because we are giving bolus, then the intensity will be more in the right side structures, so it will happen more. But if to avoid this, we can use with low dose and continuous infusion, so that it will give the plateau phase and it will not react like this. So the mechanical index used for typical imaging, as we discussed, 0.9 to 1.4, microbubble will be rapidly destructed, and destroyed. So result in dramatic reduction in the contrast. So we have decreasing the mechanical index to less than 0.3, so effect is preserved. And so many times we just inadvertently don't know that we have to decrease the mechanical index to less than 0.3, and we use routine ultrasound mode and we give the contrast. So what happens is just like this. In upper image, it was the 0.3 mechanical index, and image is showing there is a complete opacification of the all four chambers. And in the lower image, as we see, there is apex is very hypoechoic, and all the contrast bubbles that were there are destroyed because of the high energy beam of the ultrasound, because we forgot to reduce the mechanical index from 1 to 0.3. Next is the shadowing. So whenever we are doing the 4-chamber view, there is a papillary muscle or any calcified structure which gives you the shadow, and so that we might underestimate the cavity size, and we do not find the true endocardial border. So in the right sided image, there is a, in diastole there is a still some visible difference between the papillary muscle and the lateral border of the left ventricle, but in the lower image in systole, all the borders are merging. So this case is the shadowing artifact is really troublesome. So sometimes this can be avoided with using the other views like 2-chamber views, and also decreasing the intensity of the this infusion. Next is the apical destruction. Apical destruction means there is a hypoechoic area in the apex, and it is because of either there is a calcified structure that is present around the apex, or there is a calcified apex, or any other distal calcification. So it results in the acoustic shadowing. As we know, the ultrasound beam cannot transvert this calcified structure. So even the microbubbles are present near that, but it will not resonate because of there is a decreasing the intensity because of the calcium. So this is apical destruction. Next is the hemodynamic artifact. I think we already discussed that. The preferable streaming from the IVC or the SVC might look like there is a ASD, because it also will give you some negative contrast after the bolus injection is over. So this kind should be avoided and can be used with sometimes continuous infusion. Also the SVC flow, whenever it is near the atrial septum and we are going the ultrasound from the IVC, it will also do the same. So sometimes to overcome this, we can inject from the both SVC and IVC, and we can conclude that there is a actual atrial septal defect and negative contrast because of that or any other reason. Then there is a marginated flow. Marginated flow is suggestive of the streaming of the flow in the cardiac chambers. So whenever there is a prominent eustachian valve, so it will direct the superior vena cava flow into the atrium, and it will mimic, there will be interatrial shunt because of there is a negative contrast. So that the portion that is the superior part in the right sided image, it was not opacified because it was the flow from the SVC which was marginated and preferably streamed from there because of this eustachian valve. Next is the LV opacification for the chamber delineation. So we can always know the endocardial border delineation, and also to rule out there is any clot over there. So whenever we require this, when there is a two continuous segments that are not seen in non-contrast images, as seen in the image on the right side upper image, the apex and the lateral wall of the ventricle is not well visualized, which will result in the false estimation of the ejection fraction by Simpson method. So in lower image, after injecting the contrast, complete endocardial delineation is done. So in right sided study, the difference between ejection fraction in contrast and non-contrast study is not much. If less than 2 segments if almost all the segments are visualized, but if more than or equal to 2 segments are not visualized, then the difference in the EF is much higher. So in that cases, we can use contrast to accurately delineate the endocardial border, and then we can apply the Simpson's method. So this is study showing same when we doesn't have the true endocardial border, and compared to right side where we can completely take the image from the bubble contrast, and we can take the Simpson method, which is comparable to cardiac MRI even whenever done like complete delineation of the. Then LV structural abnormalities. So these are the abnormalities we can be picked up by the 2D images, but many times the windows are not good, and some structures we might not get good images. So in that case, we can use the contrast to accurately identify like apical variant of the HOCM, LV non-compaction, apical thrombus, pseudoaneurysm, or any rupture. So this is the apical variant of HCM. In 2D image, the image quality is not good, so we might miss it, or we might label it as concentric LVH, or we just dismiss it as the normal echo. But whenever we have inserted the contrast, it is giving the true nature, like there is a on the apex there is a severe concentric LVH, and the S of the spade appearance is also visualized on the right side the image, suggestive of the apical variant of the HCM. So on the right side of the image there is a multiple irregular thickening of the apex and also the lateral wall with some crypts in it. So this might be some concentric LVH or the artifact. So whenever we injected the contrast goes into that crypts, and it suggests that there are the true crypts, and this is the case of the LV non-compaction. Then the intracardiac mass. The echo is not reliable to assess the nature of the mass. It can only give the anatomical location and the attachment, but some estimate can be taken from the bubble contrast, and it gives some amount of the vascularity. So thrombi are avascular, so it will never do any enhancement. And some stromal tumors like myxoma are also avascular, so it is also hypo-enhanced. But some tumors like highly vascular or malignant tumors, the enhancement will be also more. So we can somewhat differentiate from this. Then this is the LV thrombus. So LV thrombus, many times in the right side image as we show, there is a thrombus seen by the white arrow. So we think this is a LV thrombus because the patient was the case of the dilated cardiomyopathy with severe LV dysfunction, and in that case if there is a apical hyperechoic structure, we will generally think of the thrombus. So we have then confirmed it with the ultrasound contrast, and on contrarity, the contrast shows there is a complete opacification of the left heart chamber, and there is a delineation of the endocardial border. So it is suggests that whatever seen in the upper image was the artifact, and it was not true LV thrombus, and there was no thrombus in this case. Same thing is a pseudoaneurysm. On the apical side of the left ventricle, there is a outpouching seen, and which looks like communicating with the left ventricle. So we have confirmed with a contrast study, and after some cycles contrast appeared in that pseudoaneurysm cavity also. So it was confirmed that the cavity was communicating with the left ventricle, and it was the part of the left ventricle. The next is intracoronary contrast. This was the very useful thing whenever we are thinking of the septal ablation in the HOCM. So before doing the alcohol septal ablation, whenever we have identified the septal branch for ablation, we just insert the contrast, and this contrast should be seen on the echo, and if it is going to the whenever we target the ablation, then and then only the alcohol part is ethanol part is injected in that septal. Otherwise we have to choose the other branch, and if it also compromising the other normal LD myocardium, then we might ablate the alcohol septal ablation, and we then go for the surgery. So before doing alcohol septal ablation, contrast echo and the location of the septal relation to myocardium is almost very important. And this is myocardial perfusion imaging. This is a topic which can be have been evolved very much, but because of there is a good other imaging modalities are available, like nuclear imaging, perfusion scanning with technetium and thallium, also the cardiac MRI. So this use is also not been seen practically on day to day. So we will just go into the some understanding and the physics part of it. As we discussed, the very high mechanical index more than 1.5 destroys all the micro bubbles. So first we will inject the contrast, then we will produce the very high mechanical index. So it will destruct all the microbubble, then we will decrease the mechanical index. So the myocardium will be again reperfused, and the microbubble will be replenished, and it will depends on the cardiac cycle, around 5 to 7 cardiac cycles. So if the myocardium has no disease and perfusion is normal, then it will be replenished. If there is a decreased perfusion, then it will not replenish, and it will show us as the dark or patchy area. So in 3 images we have done. First image, the completely white out is a very high mechanical index imaging, which had destroyed all the contrast. On the next cycle, LV is opacified because of we have injecting the contrast continuously, but the myocardium is not opacified because it will take 3 to 5 cycles. So the lower image is after 3 to 5 cycles, and myocardium is also opacified. So next, the thing is myocardial opacification is indicates the perfusion, that quantity of the perfusion, but the replenishment time, it suggests of the how the blood flow velocity is there. So if there is some stenosis, but it will not decreasing the total myocardial demand at the rest, then it will opacify as normal. That segment will opacify as normal, but the replenishment time will be more. So these are the clinical use to detect coronary artery disease during stress echocardiography and differentiate viable versus infarcted myocardium in ACS, and also assess for revascularization viability. So the myocardial contrast perfusion imaging can be combined with pharmacological stress, either dobutamine or vasodilator such as dipyridamole or the adenosine. So the perfusion defect, if demonstrated before stress, it is suggestive of that area is either non-viable because of there is no perfusion. But if there is a normal perfusion during the rest, and then with stress, if it decrease in the perfusion, we can see that that part is having stress-induced ischemia. So this is results are comparable with the nuclear imaging like technetium or the thallium stain. But the issue is that is routine it still needs to be evaluated, standardized and validated in the routine practice, and also the cost effect of this commercial contrast agent is very high, around 6,000 to 7,000 for one vial of the contrast agent. So it is a kind of time consuming. Also the standardization is also not great. Normal range are also not laid down by the associations. So in this case it was the trend of using ultrasound contrast for the perfusion imaging and the stress imaging has been not in the clinical practice, and we are using other modalities to assess for these conditions. So on the future perspective, if there is some contrast agent which are very available and in the cheaper rate, we might routinely use this kind of the imaging to instead of the other cardiac MRI or other imaging for rapidly evaluate the viability and other thing. So all over whatever the part we have discussed of the left ventricular contrast is generally more of like a theoretical discussion only, because we are not generally doing the clinical day-to-day life contrast in left-sided heart chambers. But with saline bubble contrast in the right-sided chambers, it is very useful. In selected cases, it might give you the diagnosis even though all the other imaging modalities have failed to do so. Thank you.